Thank you for logging in for today's online teaching session. I should really thank Dr. Julius from the Sri Ramachandra Institute of Medical Sciences, Chennai, for first, agreeing to moderate today's session and also putting, a good case presentation with some discussions on hepatoblastoma. So Dr. Julius doesn't really need introduction to this audience. He's one of the senior member of the Pediatric Hematology Oncology fraternity. He's currently professor and head of Pediatric Hematology Oncology at Sri Ramachandra Institute of Higher Education and Research. So thank you, Dr. Julius, for moderating today's session and putting a very esteemed faculty together. Dr. Julius has really put together a very accomplished expert stalwarts in the field to discuss the various aspects of hepatoblastomas. We have Dr. Mukul Vij, who is a senior consultant histopathologist. He is currently at Dr. Rela Institute and Medical Center. So good afternoon, Dr. Mukul. Dr. Arunan, he is professor of radiology at Sri Ramachandra Institute of Higher Education, and Dr. Prakash Agarwal, who is a professor head of pediatric surgery at Sri Ramachandra Institute of Higher Education and Research. We'll have Dr. Janani, who is IAP fellow at the Sri Ramachandra Institute, to present the case for today. And as usual, we'll have the a didactic, which is interspersed with the cases basically on hepatoblastoma, and we'll discuss various aspects of hepatoblastoma diagnosis, management, and controversies around hepatoblastoma. So with that note, I request Dr. Julius to take the session forward. I've been requesting every week on, so friends, we have been, this platform has been, given to us by ECHO, and one of their requirements has been to have the videos on, because these are supposed to be interactive sessions. My request to everyone is please keep the videos on so that at least also the faculty can see the faces. They're not talking to a blank screen. And also, as it is a requirement from the ECHO point of view. So please post your questions on the chat box, or after the, you can also ask them later on once the discussions are over. So, so please keep your videos on. Thank you, Dr. Julius, and over to you.
Good evening, everybody. So this session on hepatoblastoma, Janani, you can project the slides now.
Yes, sir.
So as Dr. Sunil mentioned, Dr. Janani is my fellow who is going to present this. And the next slide. And we have the experts. Dr. Mukul is one of the very notable person for liver pathology. He works with Mohammed Rela, who is one of the Guinness record maker in pediatric liver transplant. So my knowledge about hepatoblastoma considerably increased when I joined the team of Dr. Mohammed Rela, and also where I work in Ramachandra and Childress, 3 hospitals together. The most important predictor for the outcome, I would say without exaggerating, that is a good pathologist contributing to the finer details that you will understand from some details. That is Dr. Mukul. And Dr. Arunan and Dr. Prakash are my team from Ramachandra. Dr. Prakash is one of the best pediatric surgeon who does a lot of surgeries regarding in pediatric oncology. And I have worked with him for neonate with the liver masses being resected. And Dr. Arunan is one of the person who is very great expert of PET scan. Now, in the last 6 or 7 years, he is one of the most important person for our tumor board in Ramachandra. So I'm happy that the team is very good today to discuss the facts. Next slide. Okay, the objective of this is, if you get a phone call when you are in a ward that there is a child, 2-month-old child or a 9-month-old child or a 8-year-old boy has come with an ultrasonogram proven liver mass. When you walk from the place to the OPD, what all will come to your mind? That will be discussed here. What all should come to your mind? But will be only mentioned the things which should come to your mind if there is a referral with a liver mass from the pediatric oncology perspective. But in depth, we'll be discussing only hepatoblastoma. from the exam perspective and also for the clinical practice. This I am insisting because this session, I am not going to keep like a conference or like a seminar. This is exactly how you should present in the exam. If there is a hepatoblastoma case is allotted to you, the same thing after passing the exam, how confidently you can manage a patient with hepatoblastoma up to the level of liver transplant or post-liver transplant. So we will be discussing only the facts. I will make one statement, but in depth that statement that you have to read. And I am going to allow the pathologist and radiologist and surgeon to talk from their part also, because that is something which is very important for you to have a basic understanding about hepatoblastoma. Next slide. So as I told you, what all should come to your mind, I'll just read that. Okay. Hemangioendothelioma. So I'm just saying liver mass. So not with any age, not with any features. What all should come to your mind in a liver mass? Hemangioendothelioma, mesenchymal hamartoma, hepatoblastoma or hepatocellular carcinoma, focal nodular hyperplasia, hepatic adenoma, metastatic neuroblastoma, biliary rhabdomyosarcoma, undifferentiated embryonal sarcoma of the liver. All these I have seen, but only in the last 20 years, not in 2 months. So for you, if there is a liver mass, the most common, 90% will be either hepatoblastoma or hepatocellular carcinoma. Okay, that you have to understand. So don't think of rare things. But if there is a cutaneous hemangioma with the coagulopathy, with thrombocytopenia, with hypothyroidism in a young child less than 6 months with CCF, that is not mentioned here, then your thinking will go to hemangioendothelioma. So you can look at the extreme, thrombocytopenia, thrombocytosis. If there is a newborn born with hydrops and there is a mass which is cystic, young age, mesenchymal hamartoma. And then one point, if you understand about focal nodular hyperplasia, in cancer survivors, it is common. That's only one point. There are many points. Hepatic adenoma is something which links between a hematology and oncology. If you treat both, if you look at the Fanconi's and then you treat them with anabolic steroids, come to oncology department with liver mass, hepatic adenoma. And one more interesting thing is, if there is a newborn baby with liver lesions, think of a stage 4S neuroblastoma also. One important thing regarding biliary RMS is jaundice. One important thing strikingly absent in hepatoblastoma is jaundice. Hepatoblastoma usually will not have jaundice. Biliary RMS usually will have jaundice. An undifferentiated embryonal sarcoma, the metastasis is very typical. Lungs means is hepatoblastoma. Lung, pleural and peritoneal is undifferentiated embryonal sarcoma. So I'm not going to give weightage to the other things other than hepatoblastoma. This is our objective this time. Okay, next, start with the case presentation, Jenny.
Good evening, everyone. Starting with the first case for our session. So presenting a 9-month-old female child who was born to a non-consanguineous married parents. It was a first-born child, presented with abdominal distension for the past 2 weeks.
Okay, now, if there is a age mentioned in a phone call when you are going towards, if there is a 1-month-old child liver mass, you should know that hepatoblastoma is uncommon. And 8-year-old child liver mass, hepatoblastoma is uncommon. So that is the first point, age-related diagnosis. In my thinking, lesser the age, the more common is hemangioendothelioma or mesenchymal hamartoma. More the age, it is either hepatocellular carcinoma, focal nodular hyperplasia. So hepatoblastoma, even if you look at the screening for hemihypertrophy, the legally you can stop screening by 4 years because 90% of hepatoblastoma occurs less than 3 years. But means it is something which is very rare. You don't need to mention the exam. That is why I told you one side exam teaching, another side is clinical practice. So with Dr. Muhammad Rela Mukulvich, we have seen a 1-month-old child with hepatoblastoma, proven, treated and well. And in child trust, I have seen and managed a 3-month-old child hepatoblastoma managed and well. So this is only atypical. So MBBS level of teaching, we normally don't tell the atypical things. MD pediatrics will mention and tell them, do not tell for exam. But this is a third level of studying. This is a specialty that you should have a rational thinking that which should be told to the exam, which should be taught in the clinical practice. So hepatoblastoma exists in lesser age also, which is uncommon. And hepatoblastoma occurs in older children also, but it is uncommon. Next slide. Okay, how do hepatoblastoma present? So she said incidental mass or not. There are many symptoms and signs, but the most important thing is strikingly absent jaundice. Only in advanced cases. I have never seen a jaundice in hepatoblastoma. But one thing which is very important for exam point of view is precocious puberty do exist in hepatoblastoma, but I have not seen. Next slide. How does hepatoblastoma present with precocious puberty is when the tumor secretes beta HCs. So that is one important point. This is all typical exam points. But if you have precocious puberty in pediatric oncology, if you have a central cause or adrenal cause, adrenocortical carcinoma, or germ cell tumor, juvenile granulosa tumor of ovary, this all should come to your mind, but you should do AFP also for any precocious puberty. So 100 times if you see a precocious puberty, one will be hepatoblastoma. 100 hepatoblastoma, if you see, one will have a precocious puberty. I don't think any center will see 100 hepatoblastomas during your fellowship or until you retire. It is very, very difficult, except for hospitals like TMH or very big institutions. So most likely you won't see precocious puberty in hepatoblastoma. Next slide. Okay, Janani will continue.
So going ahead with the birth history of the child was born out of in vitro fertilization after 6 years of marriage. It was a term baby born out of normal vaginal delivery. It weighed 2.8 kgs at birth. The child cried immediately after birth. It required NICU admission and required phototherapy for 48 hours. She was developmentally normal for age and vaccinated up to date. There was no similar family history.
Okay, now in this history, the important points will be highlighted by Janani now. In vitro fertilization. If you look at your nursing staff or residents, when you work for 1 or 2 years in oncology, you will be asked a question, sir, there are many parents who are having cancer children. These children are born out of assisted reproduction. That is an observation. Will that be quoted as a scientifically relevant increased risk for having cancer children? Is a research question which we will answer. And then next point is prematurity, low birth weight, NICU admission, and a family history. These points are relevant or not. So as I told you, the objective is exam one side, clinical management another side. And I am not going to have a separate lecture and a separate case presentation. Both are combined. So my next slide. My first point is among the prematurity, low birth weight, IVF pregnancy, or neonatal admissions needing phototherapy, most of the things are linked, but all these are linked only in one point is low birth weight. Lower the birth weight, higher the risk of hepatoblastoma. So IVF babies, if they are premature and born with low birth weight, they are more prone. It is not only the IVF. Next slide. So if there are many researchers, this is COG, the conclusion is there is not much of evidence to link IVF pregnancy and hepatoblastoma now or any other malignancies. But your observation may be correct because hepatoblastoma occurs in low birth weight and assisted pregnancies lead to prematurity and low birth weight. So it is the low birth weight which is more important. That is something which is you should understand. Next slide. Okay, now no significant family history. Many parents would have asked you, my child has got leukemia. Can I have next pregnancy? Can I have a checkup for the another child? Next child also is having petechiae purpura. All these are nightmare for the parents. You cannot exaggerate or even understand how much trauma they go through when a child is diagnosed. Obviously, you are all fellows. You will understand. But most of the time, we would counsel them, no need to worry about the next child. It is not genetic, okay, except one tumor. Retinoblastoma. Retinoblastoma, siblings have to be screened. Parents have retinoblastoma, children have to be screened. But hepatoblastoma, there is a link by the APC gene. If they have a APC gene, the hepatoblastoma can run in families. Again, the credit goes to Muhammad Rayla. It's not a happy news, but it's a sad news that I have seen a family who had 4 children from Oman. The first and the third child had hepatoblastoma. One was done transplant and alive and well. Second, third sibling. There is a second child who had hepatoblastoma, is treated with resection and chemotherapy, and child is well. So, but I don't know, I'm not sure whether you can quote this for the exam, because most of the examiners may not have seen a hepatoblastoma running in the families. But please remember that. But telling to the patient or investigating that, it is not that significant. If you think even the low birth weight babies are not having a screening for hepatoblastoma. Okay, so hepatoblastoma in families is almost does not exist, but I have seen one child and it is reported also in the literature. Next slide. Continue.
Going ahead to the examination, there were no dysmorphic features. There was no hemihypertrophy. The child was vitally stable at presentation.
Okay, next is the dysmorphism. So not all leukemias you look for dysmorphism. Not all Ewing sarcoma you look for dysmorphism. There are some tumors in pediatric oncology you have to look for dysmorphism. Is one important thing is hepatoblastoma. Second important thing is Wim's tumor. Okay, see, that is something which I like in our career is we don't start with pediatric oncology like dental. Even there were a lot of discussions whether the ophthalmology should go through MBBS or start with ophthalmology. But in pediatric hemato-oncology, I would strongly recommend that the association with the pediatric hospital, university, you get trained from pediatrics and then always be attached with pediatrics. Then only you can pick up a Beckwith-Wiedemann syndrome and a glycogen storage disease. And you look at an isolated hemihyperplasia and then screen for hepatoblastoma. Next slide. What is a legal thing in isolated hemihyperplasia is if a child is vaccinated from birth to 3 years and third yearly, if a child has got hepatoblastoma and the child has got isolated hemihyperplasia, the parents can sue saying that it should have been screened and found out. If you find out in pretext 4 and then recommend a transplant, because legally you are supposed to take AFP and ultrasonogram every 3 months until 4 years of age. Some guidelines will recommend 7 years or 5 years, but there's no guideline which say no need to screen. So this is some dysmorphism is very important. Every hepatoblastoma, when you write the history, you have to say no evidence of precocious puberty, no evidence of hemihypertrophy, no evidence of dysmorphism, or no syndromic association. Next slide.
So going ahead with the systemic examination,
continue.
on abdominal examination, it was a firm to hard, non-tender, ill-defined mass over the right hypochondrium extending up till the umbilicus. The genital examination was normal. Ultrasound abdomen was done outside, which showed a large mass lesion of 11 by 10 by 9 centimeter involving both the lobes of the liver. Right involved more than the left. Hence, the child was referred here for further management. So the initial blood investigations, the hemoglobin was 9.5, total leukocyte count was 12,500, and the platelets showed thrombocytosis of 11,90,000. So
this will be always striking, the thrombocytosis. So if I am an examiner for your FNB exam or IAP fellowship exam, if the child has got hepatoblastoma, I will definitely ask why there is thrombocytosis. So please answer 3 words. Interleukin 6, thrombopoietin will be increased because of interleukin 6 is produced by the tumor, and then increased thrombopoietin will increase the megakaryocyte production. So finally the answer is only one point is that is interleukin 6. Okay, so yeah, the thrombocytosis is striking. Next slide. This is a true patient. So we are having the same true facts only, but the radiology may be different. So now Dr. Arunan will talk about the radiological features of a liver mass. He will differentiate hepatoblastoma from other differential diagnoses. Arunan, you are there? Arunan is there. He has to unmute and talk.
Yes, sir. Can you hear me now, sir?
Yeah, I can hear you. You can start.
Yes. So this image is the first two images on the top row are two images, contrast enhanced CT. The first image on our left is the contrast enhanced CT in the arterial phase, and the next one is the image in the venous phase. Now, in the CT, we can see that there is a mass, a heterogeneous mass, to keep it simple, a heterogeneous mass with multiple patchy areas of enhancement occupying the right lobe and also a part of the left lobe. That is, it is occupying 4 sections. If you go to pretext, that is the right lobe and also the medial segments of the left lobe. That is the first 2 images. The third image is a coronal section depicting the same. And the CT chest, we did a CT chest also, which shows that there is no evidence of metastasis. Now, with this age group and increasing AFP and other clinical features, our first diagnosis will always be hepatoblastoma. Now, of course, it is not always hepatoblastoma. You may ask, what are the other differential diagnoses? We should not always have a narrow vision. Always broaden your horizon. Keep other options also open. Okay, so our first diagnosis will be hepatoblastoma. Why? We can also say hepatoblastoma, one, because of its striking features, like large mass with the age group and enhancing characteristics. Okay, but let us also see the other differential diagnosis. Next slide. Next slide. Yes. Now, whenever we come to focal liver masses, we divide the liver masses as epithelial or mesenchymal, and you have your benign varieties and your malignant varieties. Now, imaging wise, let us look at lesions which look at least near similar to hepatoblastomas. So for our differential diagnosis discussions, the commonest, because of its age group and the closest resemblance, would be the infantile hemangioendotheliomas. Now there are 2 types. One is the focal type and also the multifocal or the diffuse types. Now, in infantile hemangioendotheliomas, these are very vascular tumors, or more or less vascular dysplasias. So in these lesions, you will have intense enhancement, that is peripheral, nodular, intense enhancement in the arterial phase, and progressive fill-in. Okay, in contrast to hepatoblastomas will have a patchy enhancement, but here you will have intense. The word intense is very, very important. Intense peripheral nodular enhancement, which will progressively increase over the different phases. You will hear of venous phase and the delayed phases. So as it progresses, you will see that the enhancement increases. That is very, very characteristic of infantile hemangioendotheliomas. The next slide. Okay. The other DD will be your focal nodular hyperplasia. In focal nodular hyperplasia, it is usually a solitary lesion. Okay. Yes, again, it will have enhancement very, very similar to hepatoblastomas, but the characteristic sign is the central scar. You will see that there is a arrowhead showing our central scar that is very, very characteristic of focal nodular hyperplasias. And also you will see that it is usually single and it is very well circumscribed. So that is a second DD is always focal nodular hyperplasias. But of course, in such cases, our AFP will be near normal. Next slide. Yes. The other differential diagnosis for any mass lesion in a thing should always be mesenchymal hematoma. Textbook says that these are usually cystic lesions with septations or minimal solid components. Okay, but nevertheless, you can have atypical appearance like we see in our cases. Like these solid components can be more, but the presence of cystic components point more in favor of mesenchymal hematoma or other or maybe malignant mesenchymal tumors, rarer malignant mesenchymal tumors. Hepatoblastomas have very less cystic component. So these are our main differential diagnosis: infantile hemangioendotheliomas, focal nodular hyperplasias, and mesenchymal hematomas. Next slide. Next slide. Yes. But is it enough to just say hepatoblastoma and let the radiologist take a back seat? No. The most important part, the coming to a diagnosis of hepatoblastoma or a HCC, or it is very simple. Anyway, you'd go in for a biopsy if it is atypical. But what is important is the pretext staging. Okay, pretext, posttext, but the important thing is the pretext staging. Now I will want to spend on 5 minutes on pretext staging. It has two components. One is the pretext group, and the other is the pretext annotation factors. Okay. For pretext grouping, we divide the liver into 4 sections. Okay. One will be our left lobe lateral sections, that is segments 2 and 3. Next is the left lobe medial sections, that is our segments 4A and 4B. Coming to the right lobe is the right anterior, that is segments 5 and 8. Then right posterior, segments 6 and 7. So let me repeat. There are 4 sections: left lateral, that is 2 and 3, left medial, right anterior, right posterior. These are our 4 sections that we need to keep in mind. Now, depending on the extent of these sections involved, we divide it into pretext 1, 2, 3, and 4. Now, to group it in each sections, you need to identify or remember the keyword: contiguous tumor-free segments. Okay, to remember is contiguous tumor-free segments. That is, let's say the topmost image, we see that a lesion involves either only the left lateral or the right posterior. We have 3 segments, contiguous tumor-free segments. Then it will fall under pretext 1. Pretext 2 will come when there are only 2 contiguous tumor-free segments. An example here, we see a lesion involving maybe both, both sections of the left lobe or both sections of the right lobe, or 2 lesions involving the extremes, left lateral and right posterior. So we have our medial and the anterior segments to be preserved, they can be preserved with surgery. Now 3 is when you have only one contiguous or only one segment, one section which is tumor free. Now whenever we see lesions in the medial segments, that's the left medial and the right anterior, it automatically falls into pretext 3. Now pretext 4 is when you have no section which is tumor free. Now this is, I think, remember it, tumor free contiguous tumor free segments. Okay. Now after categorizing it as pretext 1, 2, 3, 4, the next thing is to add the additional annotational factors, because they also play a part in deciding whether surgery is feasible or not, or also upstaging the disease. Now the annotation factors are V, P, E, F, R, N, C, and M. Now a small note on each thing, of course, is more important for radiologists as to the criteria, when it is involved, when it is not involved. But let me just touch upon this. Okay. Now V stands for involvement of the IVC and the hepatic veins. Now you will see reports saying it is abutting. Now abutting does not necessarily mean infiltration. Okay. We say it is involved only when there is a thrombus within the vein or lumen is compressed by at least 50%. And not just, it should involve the IVC or all three segments of the hepatic veins. Only then we say it is V positive, that is V positive. Again, this criteria differs in both the SIOPEL and the COG, but the latest pretext 2017 criteria states a different thing. You should have either involvement of the IVC or involvement of all three hepatic veins, or there is a tumor thrombus in either of the veins. Same thing applies for portal vein. You should have at least 50% decrease in the diameter of the vein or involvement of the portal vein, main portal vein. That is, there is 50% decrease in the size and also intraluminal thrombus, that is involvement of the portal vein. Extra-abdominal disease, that is, we look for lesions within the peritoneum, nodules in the peritoneal cavity, and they should be at least 5 to 10 millimeters in size. You can have nodules in the peritoneal cavity. F, tumor focality. Again, it is similar to our pretext, whether there are multiple lesions or single lesion. Hepatoblastomas can rupture into the peritoneal cavity. Mere presence of ascites does not categorize it as rupture or presence of intraperitoneal disease. Only when you have blood products within the peritoneal cavity can you classify it as tumor rupture. In imaging, we can make out whether MRI or CT depending on the characteristics. Again, so ascites does not characterize the lesion as intraperitoneal extension. Lymph node metastasis is common with hepatoblastomas, but more common with others, sarcomas. But again, you can have lymph nodes in the periportal region. Also, involvement of the caudate lobe. This is important because it can easily spread to the other, the adjacent segments. So again, involvement of the caudate lobe is important. Distant metastasis. Okay, the most common site for metastasis is bones. Okay, lungs. I'm sorry, the lung parenchyma. Very rarely to the bones. Okay, now again, bone scan is not the modality of choice. If you're suspecting bone metastasis, very, very strong suspicion. Bone pain can be due to paraneoplastic also, but if you're strongly suspicious, then PET CT is useful. So, directly for a bone scan is not recommended nowadays. So to recap, pretext is the grouping and also annotation factors. Pretext grouping is 1, 2, 3, 4, depending on the contiguous tumor-free sections. I think these are the keywords: contiguous tumor-free sections. The next thing is the annotation factors, wherein you see all these the following 8 criteria, whether they are fulfilled or not. Next. Okay, again, commonest, especially in our country, is the presence of nodules in the lungs. When do you call a nodule as metastatic? Especially in our country wherein we have lots of granulomas, TB presence. When will you call that a nodule is significant? 1, if you see only one nodule, then it should be more than 5 millimeters. It should be round, spherical, and it should be non-calcified. And single, if and more than 5 millimeters, then you may characterize it as metastasis. If you see 2 or more, each more than 3 millimeters. This is very important because it's common to see small, tiny nodules, 1 mm, 2 mm nodules. So if it fulfills this criteria, we may call this as metastasis. Next slide. Okay, now there has been a recent consensus arrived upon, as I think last year, 2020, it's called the Pediatric LIDATS group. LIDATS working committee has given recommendations. Okay, now the role of ultrasound. This is the initial modality that is, but should not always stop with ultrasound. You see a lesion, doesn't stop there. You have to go forward with CT or MRI. The next is MRI. MRI is the modality of choice for diagnosing and follow-up of hepatoblastomas or other liver tumors. MRI is the modality of choice. A small note on the contrast, there is something called the hepatocellular or a cellular contrast media. It is recommended, but we can use a normal gadolinium contrast also. Even that is normal gadolinium, but I mean, MRI with contrast is recommended. The next thing is CT of the abdomen pelvis. Of late, I mean, CT of the abdomen pelvis is easy. MRI requires sedation or anesthesia requirement. For convenience sake, we can use CT of the abdomen pelvis, but still recommendation is the MRI. Of course, CT and MRI is for our convenience, because it's easy to cover the whole thing, very short, and the degree of information is the same. So far, we see that degree of information is the same. But if you are looking for small foci, residual foci in the residual, the other segments, MRI is the modality of choice because CT with contrast can miss small lesions. Okay, if you want to pick up small lesions, still MRI is the modality of choice. Now, coming to the CT of chest, whenever we diagnose a hepatoblastoma, it is recommended to go for a CT of chest, at least in the initial staging phase. In the follow-up, CT of the chest is recommended only if we have rising AFP counts or if the suspicion of metastasis is high. That is your imaging recommendations. Next, staging, yes, pretext, group, and the annotations. Do we need to image if the imaging study is done outside? Not necessary, because the information can be got in with films. We can do a decent job with films. Necessity of biopsy, if the diagnosis unequivocally, you say it is hepatoblastoma with the raising AFP counts, biopsy is not needed. That is what at least the recent guideline says. Biopsy is not needed. If unequivocally, you can confidently say that this is hepatoblastoma. Next. Okay, I think over to you, sir. Thank you.
Thank you, Arnan. Janani, continue.
So coming back to our case, so at presentation, the AFP was more than 12 lakhs, beta HCG was normal, the tumor lysis workup was within normal limits, viral markers were negative, and CT thorax was normal.
So one could wonder that tumor lysis in workup should be done in hepatoblastoma or not. Routinely, no need. It's exceptionally because of the high tumor load. I have not experienced, but I have checked in the literature, there are some case reports. So please remember that hyperkalemia is very common. If there is a hyperkalemia in an infant with hepatoblastoma, rule out tumor lysis. Next slide. Okay, regarding alpha beta protein, it is a short notes. One important thing is 90% of children with hepatoblastoma will have elevated AFP and half-life is 5 to 7 days. This is something as a student I have to remember this. Next slide. Okay, normal AFP values. This is one or two important things. In infants, so there is a normal value, tabular column, you have to see this. And then please remember, up to 2 years of age, sometimes the AFP can be around 80. Next slide. Okay, if you look at this tabular column, it is taken from Indian Journal of Pediatrics, our ICMR guidelines. This says age in months, but it goes up to 720. So it cannot be months. It's a, I think it's an error. So it should be age in days. Next slide. So the important point everybody has to remember is there is a documentation in the literature that up to 2 years of age, the AFP can be up to 80. So, but if it is rising AFP during follow-up, it is a concern. But if it is 40 or 50, if the scan is normal, please take it. This is an age appropriate variation up to 80. Next slide. Continue.
So the child was discussed in a multidisciplinary tumor board, and the plan was to go ahead with chemotherapy without biopsy. And the family was counseled regarding the same. Audiology and echocardiogram was done before starting the chemotherapy. In the second cycle of chemo, port insertion was done. The child received 4 cycles of chemotherapy and had echo and audiology monitoring throughout the chemotherapy session. So there were no events like febrile neutropenia or any transfusion during the chemotherapy period.
Okay, so here the point is, it is very clear in SIOPEL that if the child's age is between 6 months to 3 years, and if the AFP is unequivocally elevated with the radiological diagnosis of hepatoblastoma, if the tumor board agrees, we can proceed with chemotherapy. That's what happened. Next slide. Okay, the same point. Next slide. Okay, now I'm not going to discuss any of these slides because this presentation will be shared with everybody if somebody wants. So there are guidelines produced by different continents. So famous is COG and SIOPEL. So we are actually following SIOPEL. So we are not very familiar with COG. That's me in my institution. Next slide. So every protocol which your institution follow or which you follow, you can thoroughly go through that protocol, follow that risk stratification and follow that guidelines. Don't take one protocol risk stratification and use another protocols because of some convenience. So if you are not doing biopsy, upfront chemotherapy, delayed surgery, it should be SIOPEL. Next slide. Okay, so this is COGs. We are not going to go through this. This has 4 categories. Next slide, SIOPEL. Okay, this is what standard practice, but most of our institution for practical purposes divide into standard risk and high risk. But please remember, there is a very high risk also. The most important prognostic factor or which we are worried is AFP less than 100 and an extra hepatic disease and a metastatic disease. These are the 3 things. Next slide. Okay, so there is a concept that after a complete surgical resection with the pure fetal histology hepatoblastoma and the normalizing AFP, you can wait and watch. That was COG's recommendation. Next slide, please. This is that study. And next comes PLADO versus monotherapy. Okay, so there is a significant evidence that monotherapy is enough. Again, coming to your tumor board, your institution. So it's nothing wrong in quoting the exam that PLADO and also a monotherapy. Next slide. Next slide. So everybody will be familiar with the PLADO. Next slide. See, in the super PLADO, there is a confusion for many students that what is super PLADO mentioned in SIOPEL 3 is for high risk hepatoblastoma. It is 2 weekly. Every 2 weeks, you give a chemotherapy, cisplatin alternating with carbo and doxo. But there is another protocol called dose dense cisplatin super PLADO. Dose dense. Next slide. So you can go through that if you are not very familiar. Not many institution uses this. Very honestly or frankly, that I am not using this. Even for high risk, I am using super PLADO only. But you should remember there is a protocol, dose dense cisplatin also is available. Next slide. Okay, so this is the common chemotherapy recommendations which you have to go through for your exam. Next slide. So SIOPEL 6 is not anything related with chemotherapy. It is related with assessing the ototoxicity. Please remember, you have to do serial audiology checkup for infants. Otherwise, you will miss out a huge ototoxicity. Next slide, please. Yeah, you can continue.
Chemotherapy. So at the start, we have discussed the AFP was more than 12 lakhs. After 4 cycles of chemotherapy, the AFP had reduced to 534 units per liter. So imaging was done after 4 cycles of chemotherapy, and the child underwent surgery, which was right trisectionectomy with IVC resection and common bile duct excision with Roux-en-Y hepatico-jejunostomy.
Now, Dr. Prakash Agarwal will discuss the surgical aspects of hepatoblastoma. Prakash, you have to unmute.
Hello, can you hear me now?
Ah, yes, I can hear you. We can hear. Go ahead.
Okay. Before I go to the management of this case, I would just like to tell that the treatment of hepatoblastoma is not completely surgical, but it has to be a team approach with chemotherapy as well as surgical resection. Though there are, as we have discussed already, the COG and SIOPEL groups, they have the different opinion, but most of the time it will be chemotherapy first followed by surgery. As we all know, surgical treatment is not the alone treatment, and especially with advanced diseases, definitely like this case, we need pre-op chemotherapy followed by response to the tumor, and then we have to plan for the surgery. Now, what is the advantage of neoadjuvant chemotherapy? We have all discussed. It makes the tumor smaller and consequently more likely to be completely resected if you give pre-op chemotherapy. But also more likely it can become more solid. The friable tissues become more solid. It becomes easier for us to operate, and the friability disappears. There is less prone for bleeding, and the tumor demarcates itself very clearly when it has metastasized to a lot of other places. Next slide, please. So pre-op chemotherapy has been seen to reduce surgical morbidity of resection and provides more time for making a definite surgical plan. Supposing we are waiting for liver transplantation, and when indicated, we should give chemotherapy first so that we can buy some more time before we plan the donor and which hospital to refer, where is the transplant surgeon available. Accordingly, we get some time if we start pre-op chemotherapy. And when we have extensive procedures, then chemotherapy, pre-op chemotherapy comes very handy. Next slide, please. So what we commonly follow is this algorithm whenever we have a hepatoblastoma for surgical resection. If it's a pretext 1, 2, 3, 4, as per the SIOPEL group, we give neoadjuvant chemotherapy for all these patients. Even in our institute, we follow this protocol where we give pre-op chemotherapy, neoadjuvant chemotherapy for all these groups. And depending on the post-text, if it is 1, 2, and 3, we try to give do a resection. Supposing it has limited to one lobe, then we try to do a resection of that lobe. And if it is slightly extending beyond the left or the right hepatic lobe, we try to do a extended hepatectomy. But the COG group may vary, which we usually don't follow in our institution. But if post-chemotherapy, the post-text is 2 or 3 or 1, as per the COG group, we go ahead for resection. If it is 3 or 4 and with metastasis, then definitely they need transplant. Next slide, please. So this patient underwent a trisectionectomy with IVC resection, a common bile duct resection, and Roux-en-Y hepaticojejunostomy. So it's like a major resection with trisectionectomy, means apart from the corresponding lobe, you are removing a extra lobe. Like in the right, sorry, can I come back to the slide? Yeah. Like if you have a right trisectionectomy, you remove the section 5, 6, 7, 8. Along with that, you remove the lobe 4. Similarly, if you have a left trisectionectomy, you remove 1, 2, 3, 4. Along with that, you remove a part of the right lobe, that is lobe 6, 5, and 8. So trisectionectomy is nothing but removing a part of the extra corresponding lobe. Like in right hepatectomy, you remove lobe 4 of the left lobe, and in left hepatectomy, you remove part of the anterior lobe of the right side, that is 5 and 8. So extended hepatectomy is called trisectionectomy. And when it is involving the IVC, then you resect the IVC and try to repair it, and you do a bile duct reconstruction with a Roux-en-Y hepaticojejunostomy. As in this case, this was done in an outside center which is more experienced with liver transplantation. So the transplant surgeons can only do a very good trisectionectomy with hepatic resection and IVC resection with reanastomosis and a hepaticojejunostomy. In case this patient lands up with a near total hepatectomy, then they have to do a hepatic transplant. So they take a risk and they do a trisectionectomy. When we are doing a trisectionectomy, we have to keep in mind that if this is not fit for the survival of the child, then you have to go for hepatic transplant. So hepatic transplant is a very close option when we are doing a trisectionectomy if you are not leaving adequate part of the liver. So that part we have to keep in mind. Next slide, please. So regarding the lobes of the liver, we have already discussed. What I want to show in this diagram is, you can see the left and the right lobe of liver. Then when we do a trisectionectomy, we remove a corresponding part of the other side of the liver. Supposing in left we are removing 2, 3, and 4, we remove 5 and 8 along with that to call a left trisectionectomy. As you can see in this other picture, there is a huge part of the liver that is removed along with the tumor, and whether the child will survive with the remaining liver, that is a doubt. Then you should always be prepared for a liver transplant when you have resected the IVC and done a Roux-en-Y hepaticojejunostomy. Next slide, please. I would not go into the details of the surgical aspect, but with all lobectomies, what we try to control is the inflow and the outflow blood supply. Inflow being by the portal vein and the hepatic artery, outflow by the hepatic veins. So we have to control both the sides. Supposing we are doing a right lobectomy, we ligate the right hepatic artery, the right portal vein, and the right hepatic vein. Portal vein and the hepatic artery being the inflow, hepatic vein being the outflow. So once you close both these inflow and outflow, you get a proper demarcation. Then you do a right hepatectomy. Similarly, in the left hepatectomy, you control the left hepatic vein, left portal vein, and the left hepatic artery. So inflow and outflow, once you close, the liver will demarcate and you can remove that part. But what do we do in trisectionectomy? Apart from the, supposing we are doing a right hepatic trisectionectomy, we ligate the right hepatic artery, the right cystic duct, the right portal vein, and the right hepatic vein. Once you do that, along with that, you ligate the middle hepatic vein also. In both the trisectionectomy, we have to ligate the middle hepatic vein, which is the outflow tract, which will be supplying the other part, and then the individual blood supply to that lobe. So that is what is trisectionectomy, which is called a extended hepatectomy. So I would not go into the details of the surgery. I can show you some good pictures of a right hepatectomy. We can go on to the next slide, please. So you can see in this pictures, operative picture which we have done in our institution. This is a right hepatic hepatoblastoma. You can see that white color tumor which is bulging out of the liver, and we have identified the cystic artery, the cystic duct, the hepatic artery, portal vein. The blue one is the portal vein, the blue ligatures. The left and the right portal vein has been dissected. The left and right hepatic artery with the red color loops has been identified, and the duct hepatic duct with the yellow color loops. So yellow color loops separates the left and the right hepatic duct, and the blue color loop separates the portal vein, and the red color the hepatic artery. Once we have identified all the three inflow vessels, then we go behind the liver to identify the hepatic vein. Then we ligate the corresponding right hepatic artery and the right hepatic vein and the right portal vein, so that to do a right lobectomy. As you can see in this picture, the lobectomy is in progress, and the other picture, the lobectomy has been done. The left lobe has been left behind with no further oozing, and then we apply some Surgicel so that the ooze is not there from that side, and then we close the abdomen. So straightforward surgery for a right or left hepatectomy, but when it comes to trisectionectomy, you have to be very careful. And if you're landing up with a transplant, then you have to refer it to the proper transplant surgery team, which can do the surgery. And if the need arises, they can go in for a transplant. Thank you very much.
Thanks, Prakash. So now we are going to the pathologist. Now Mukul will explain what are the features of hepatoblastoma. When do you suspect a rhabdoid tumor when you have a differential diagnosis of small cell undifferentiated hepatoblastoma, and what is transitional cell tumor? So after Mukul finish, I will take just 5 minutes to explain some of the concepts of hepatoblastoma management. Now, Mukul, you can share.
Sure, sir. I'll share. It's visible. Okay, so I think pathology is crucial, as Dr. Julius has already told, especially in liver tumors, because hepatoblastoma we know is a very chemosensitive tumor, and SCC with these two tumors are most common. SC is the chemo-resistant tumor, so it's extremely important to differentiate them, and biopsy is the only thing which with which you can differentiate them. So coming to malignant tumors, we know these are extremely rare, and more than 60% are hepatoblastomas, remaining 20-25% are SCC, and very rare embryonal sarcomas. And there is recent increase in hepatoblastomas, I think, because of the increased survivors of premature birth. And they are typical first 3 years of life. Most are sporadic. Some can occur with syndrome also. Hepatoblastoma, if you see, it's arise from primary hepatoblast, or very undifferentiated multi-progenitor cells. There is activation of the beta-catenin or WNT signaling pathway in these tumors. Mostly are genetically stable, very few are unstable. And in the genomic analysis of these tumors have shown they have low, intermediate, or they can be stratified according to low, intermediate, or high risk categories. Mostly are single 80%. Cut surface macroscopy of this tumor is important. It shows you that you are dealing with epithelial or mixed epithelial or mesenchymal. 70% epithelial, this series we published of around 30 cases in 2016 also shows that 60 to 70% were epithelial tumors and rest were mixed tumors. You have to note down hemorrhage and necrosis in these tumors, and microscopically these tumors mimic the fetal or embryonic liver histologically. Recapitulates the hepatic ontogenesis. So these are the gross pictures of hepatoblastoma. You can see the viable tumor. These are the epithelial areas. These are the viable epithelial areas. This is the areas of hemorrhage in these tumors, and these are the areas of mesenchymal osteoid production. Here in this tumor, you can see this is a transplant done, and you can see pure. Mostly, this is 90% of this is osteoid production or ossification of the tumor. Only this yellowish area is epithelial tumor. More than 90% was ossified this tumor. So macroscopy plays a role, and you can and then you have to cross it. You have to map this tumor and cross according to that. The most common what we see is epithelial type in hepatoblastomas, and fetal type. First is fetal type. Fetal type is basically shows uniformly small polygonal cells with central nucleus without nuclei. There's zonation because of glycogen or lipid which becomes clear. Mitosis is rare in this. There is no necrosis of pleomorphism, and they show light and dark patterns, and they are arranged in thin trabecules. Now, the importance of this is that if this pattern is present throughout the tumor, it is considered well differentiated hepatoblastoma, and in these cases you don't need chemotherapy. This is the typical fetal pattern, what we see, you can see the zonation. These are the darker cells. These are the clear cells with clear cytoplasm. So zonation is needed. You can see a lot of extramedullary hematopoiesis in these cases. These all blue cells are extra hemopoietic cells, and you can see that if you see characteristic tumor cells, you can see very clear, very round nuclei, centrally placed. There is hardly any pleomorphism, very well evenly placed in tumor cells in sheets. So this is well differentiated fetal pattern. Immunohistochemistry now also has a role in hepatoblastomas, and you can read markers like sometimes we do. This is glycan 3 showing typical pericanalicular pattern. This is cyclin D1 staining. This is typical membranous staining in hepatoblastoma. This is granular staining for Hepar, and this is strong glutamine. So this kind of pattern, if you see, if you are not sure in biopsy that what kind of tumor you are seeing, you can do the immunohistochemistry, which can confirm the findings. Another is crowded pattern. Crowded is a type of fetal pattern in which there is no zonation and you see a lot of mitosis. You don't see any zonation. You only see darker eosinophilic or amphophilic cells. In this area you will see more than 2 mitosis per 10 high power field, and you can also, this area is intermixed with the fetal and embryonal component of the tumor. You don't see pleomorphism or atypical mitosis in these cases. So this is a crowded fetal pattern, which is showing sheet-like cell. There is no zonation. You can see a lot of eosinophilic cells arranged in sheets, and here you can see arrangement in trabeculae, and you can see mitosis. If you can see in one field, in one height, you can see mitosis. So more than 2 mitosis in more than 10 of these fields, it will characterize as crowded fetal. In this case, you can see 2 mitosis in one field. So this crowded fetal. And again, if you do this glycan 3 marker, it shows very strong expression, confirming that you are dealing with a crowded fetal pattern. Then embryonic hepatoblastoma is a pattern which recapitulates the embryonic, the cells present in the embryonal stage of the liver. So they show very high nucleocytoplasmic ratio, scant cytoplasm with indistinct border. The cell density, there is very high cellularity in these areas. Frequent mitosis you can see, necrosis you can see, and they present as S-MAG, glandular or pseudo-rosate pattern, and also can you show myxoid chain. This is a embryonal hepatoblastoma. You can see this is a fetal type pattern. You can see these eosinophilic cells, and here you can see embryonal pattern, very dark. Most of the tumor is showing nucleus. All these blue is and they are arranged in pseudo-rosate or glandular pattern and showing a lot of mitosis. So this is embryonal. Again, you can see sheets of embryonal component in the tumor. Macrotrabecular is one of the patterns which sometimes you see in tumors. This is basically arrangement, or this more it's not histologic subtype but only a morphologic growth pattern in which you see cells are arranged in macrotrabecular, which are more than 5 cell thick. So you can see this is a macrotrabecular pattern in 2 of the hepatoblastomas. If you know these patterns, you need to note it down. And if the tumor is mostly composed of this pattern, it's important that we need also do genetic studies in these tumors. 2 types of macrotrabecular patterns have been described: MT1 and MT2. MT1 is more closer to SCC type, and MT2 is closer to the fetal or embryonic type. Then another important part to note in all the hepatoblastomas by pathologists is small cell undifferentiated hepatoblastoma. This pattern is important because this is considered from the start as a very worse prognosis in these tumors. And basically, these will show foci of small cells with very high nucleocytoplasmic ratio, pale vesicular to hyperchromatic nuclei, scant cytoplasm, and indistinct cell borders. They may grow in diffuse pattern or can occur focally. And usually in these panels, the INI1 is preserved. INI1 loss is a marker of rhabdoid tumors, which I'll show you later. In these small cell areas, what you see in hepatoblastoma, INI1 is preserved. So they are not rhabdoid tumors. They are part of the hepatoblastomas with INI preserved. And now it has been suggested that maybe these tumors which have INI preserved, the small cell undifferentiated, may not be associated with worse prognosis. Only the INI1 loss, which are a part of rhabdoid tumors, are associated with worse prognosis. So this is, you can see, these are the small cells. You can see the embryonal cell here. These are arranged in sheets. They have round to oval nuclei here. This also you can see sheets of small cell undifferentiated cell type, and you can see mitosis in this. Is important. Sometimes they can form very small cell clusters, or they can be mixed very intermingly with the fetal or embryonal cells. So IHC might help you. So they are positive for vimentin. This is vimentin. This small cell cluster, they can easily be mixed. So vimentin, they are positive. This is INI1. So what the tumor which I showed you is INI1 positive. So it's not a part of rhabdoid tumor, it's a part of hepatoblastoma only. They will show loss of heparin and glyphrin. That's how you can confirm that we are dealing with small cell undifferentiated pattern in hepatoblastoma. Also, if you do beta catenin, you will see nuclear beta catenin staining, which you can see here, which you can see the nuclear as well as cytoplasmic staining in these small cell undifferentiated tumors. In some of these tumors, you can also see cholangioblastic pattern, which they can arrange in the form of ductules, and they need to be differentiated from reactive ductules, or these are part of the tumor. So beta catenin staining will help. Nuclear and cytoplasmic staining is present in the tumor. The non-tumor will only show membranous staining. Pleomorphic again is a hepatoblastoma. Again, they may show they are like fetal or embryonal, but they show nuclei. They have eosinophilic cytoplasm, and they show a lot of pleomorphism, and they can also show increased mitosis activity and conspicuous nuclei, and they may look like SCC. They may look like SCC also, and sometimes it can be very difficult to suggest that you are dealing with hepatoblastoma or SCC. Mostly you see these cells post chemotherapy, so they are considered a part of post chemotherapy in a tumor spectrum. And you can see here, you can see the pleomorphic pattern of the tumor. You can see very large nuclei in the very large cells with nuclei, hyperchromatic nuclei, and here's the typical fetal hepatoblastoma here, and this is the pleomorphic type. So there is a lot of pleomorphism in these cells with mitosis also. Many of the hepatoblastomas, around 20 to 30%, can show mixed pattern in which you can see epithelial as well as mesenchymal. And this mesenchymal is also part of the tumor. It's not just metaplasia; they are integral part of the tumor. If you do beta catenin, they will be positive of that. So in this, you can see osteoid. You can see osteoid in the tumor. This is again epithelial hepatoblastoma. You can see osteoid production here. There's also fibrosis stroma here, and you can also see presence of fat. And 20 to 30% of cases will show that. And one rare variety is steroid hepatoblastoma, in which you can see various kind of epithelium, brain tissue, or also presence of melanin. These are very rare, and if you see this, we need to diagnose them, and we need to interpret them in the biopsy. Post chemotherapy, we also need to comment on the post-chemotherapy changes, which you can see a lot of macrophages here, pigment-laden hemosiderin. You can see these piliosis-like changes in the embryonal hepatoblastoma, and you can also see piliotic-like changes with fibrous walls. Prognostically, vascular invasion is also one of the important factors which we need to comment on in resection as well as explant specimens. In this hepatoblastoma, this was a mixture of fetal and embryonal hepatoblastoma. You can see it invading a portal vein. You can see the tumor embolus, and it's a sign of poor prognosis, and they can metastasize. The one tumor which Dr. Julius talks about is transitional tumors. Now we don't use that term. Now the term which has been recommended by the 2014 modern pathology paper is hepatocellular malignant neoplasm, not otherwise specified. And this is a very gray area, very difficult to diagnose. I think very rarely you can see these tumors, and they show, it's very heterogeneous. They show a lot of pathological pattern. They can show from fetal, embryonal, pleomorphic, SCC type changes. They can show, or they can show intermediate cells, which are in between hepatoblastoma cells and the SCC cells. So they can show macrotrabecular pattern, pleomorphic, multinuclear, all kinds of pattern apart from intermediate cells. In these cases, they are usually above 8 years of age, this is important, and they have high AFP. AFP can be in thousands or in lakhs. That is important for these tumors. And like this is one of the tumor which was diagnosed elsewhere as hepatoblastoma at 11 years. It presented at 8 years of age, and then again it recurred at 11 years of age, which was detected at our institute. Maybe this is the kind of tumor they are. They are not fitting exactly into. This was the whole tumor was like this. There was no other fetal type or SCC type. The whole tumor was like this. It showed vascular invasion, and the cells character, if you see, is between the fetal and SCC type, which I show you later. And this can be a part of this malignant neoplasm NOS. Again, these are very rare tumors, and they should be reviewed at an expert pathology center so that we can characterize these tumors and more genomic studies can be done. SCC, again coming to it, 2 minutes for that. So 20%, 80%, 70% hepatoblastomas, 20% are SCCs. They are basically two groups. One are non-cirrhotic and other are chronic liver disease, basically metabolic and genetic disorders. And we have seen in tyrosinoemias in our center, BSEP, MDR3, TGP2, biliary atrasias, and very rarely hepatitis B viral hepatitis. which is very in India. Viral hepatitis associated SCC in children is very low because of the vaccination, which we also suggested in the paper we published. So this is the typical case sent by Dr. Julius only. You can see the biopsy of this tumor. It's for needle biopsies with high AFP, and you can see this typical very large cells with a lot of intranuclear inclusions, moderate eosinophilic cytoplasm arranged in trabecular pattern, and strong glycan-3 and Hep staining. This is the typical morphological spectrum of pediatric hepatocellular carcinoma. This presented with metastatic at start. They are actually very, very bad tumors, SCC in pediatric. This is the case of our case, Hepatoblastoma, in which you can see a tumor of tyrosinemia SCC. You can see this tumor moderately differentiated. You can see multinucleation also and dysplasia also. Another tumor you can see, this is one of our cases. You can see in BSEP PFIC type 2. You can see this tumor again. It shows clear cell areas in this case. And TGP2 are another very rarely, only 2 cases are published in the world, one by us and one by nicely. You can see this tumor in a case of TGP2 PFIC type 4, TGP2 deficiency, and again this very rare tumors you can see. This is a clear cell pattern SCC in a case of MDR3 deficiency or PFIC type 3. Rarely Alagille, we recently published a series of 3 cases in Alagille syndrome also, in which you can see this SCC. Another thing is fibrolamellar, a word on it because it's important. They occur in teenagers and young adults, and the typical is scarring. They can be misinterpreted in radiology as focal nodal hyperplasia. You can see the scar, this greenish tumor, and they have a very, very characteristic histology with very large cells with prominent nuclei and a lot of fibrosis. Rhabdoid tumor, again, they are the tumors which need to be commented upon. And if your tumor shows a lot of areas with small cell and differentiate, we need to do INI1. Whenever you see small cell areas, we need to do INI1. And if INI1 is negative, that IC is negative, those tumors need to be characterized as rhabdoid tumors, and the chemotherapy has to begin according to rhabdoid, not as hepatoblastoma tumor. So this is one of our case which was treated at our centers. You can small cell. The rhabdoid with larger cells can be easily distinguished from hepatoblastoma, but the rare small cell variant like this tumor, which shows small cell and differentiate what you saw with frequent mitosis and loss of and this case showed loss of INM. The AFP in this case was 71, I think 70 or 90 something, less than 100, and very large mass occupying I think whole of the right lobe. It was resected, and I think the patient last year and is on follow up from last 1 year. I think he's okay after resection. He's still okay. There's no recurrence. What I came to know some months back. Thank you.
Thanks, Mukul. So coming back to our most important point about pathology in hepatoblastoma, for a child with normal or low AFP, if there are features of small blue cell undifferentiated, you have to ask the pathologist to do the INI loss, and if that is lost, rhabdoid tumor has to be excluded. This is very important point. Now coming back to this point, because of the lack of time, I would explain very clearly the important points only regarding the next case. Okay, the first case, a child is well and the child is doing well. The second case, now Janani, you can project the slides and I will highlight the important points.
Is it visible, sir?
Yeah. Next slide. So the child is well now. The first child has got a standard risk hepatoblastoma, operated, chemotherapy finished, AFP is well, echo and audiology is normal. Next case, we will just highlight only the salient points in the next 5 minutes so that everybody can leave after that. So this is a 10-year-old child. Next slide. So the first point I told you, phone call, 10-year-old child, unlikely to be hepatoblastoma. That is what you should remember. Next slide. But it was hepatoblastoma with pretext 3, CT chest, no metastasis, AFP was normal. Next, AFP was very high. So we were not very much doubtful because the pathologists were very confirmative of the hepatoblastoma diagnosis. Next slide. So we treated with the PLADO. Okay, this is what is very striking. Every fellow should understand. The decline of AFP was not as marked as in the previous case. So more than 3 lakhs, then 2 lakhs, then 1 lakh, then 1,09,000, then 99,000. This is not a happy news. So if the AFP decline is not significantly coming down by 1 log, 2 log, 3 log reduction. Like 1 lakh should become 10,000, 10,000 become 1,000, 1,000 becoming 100. That is how that is a rapid decline of AFP. Even in the PHO, which I studied for my fellowship in 2007, that PHO very clearly quotes a 1997 article that decline of AFP is a very significant prognostic factor, but it is not enough to change the treatment. But for prediction of the prognosis, to tell the parents, it is very important. Next slide. So this child, actually the AFP was not coming down very significantly, but we went ahead with the surgery, and then post-operative, the AFP was still high. So these 3 points you should remember: decline of AFP during chemotherapy, pre-operative high AFP, post-operative high AFP. All the 3 bad prognostic markers this child had. Next slide. So this is the article which quotes that a decline of AFP. Next slide. Next one. But when the AFP started increasing with the post-operative chemotherapy, the child was diagnosed to have CT chest metastasis. That was very expected. Age group is different. Although it is hepatoblastoma, AFP was not coming down. Pre-operative, post-operative AFP was high. Then the child ended up with metastasis. Next slide. So the salvage chemotherapy we selected was irinotecan based. So that is universally accepted that salvage chemotherapy, irinotecan, is acceptable. The child did not respond. The AFP was always high. Next slide. Hence, we used ICE chemotherapy. Next slide. That is an acceptable salvage chemotherapy. For that also, child did not respond. Next slide. Next slide. So we tried sorafenib for this child, because I had in one experience, after multiple relapses, Dr. Muhammad Raila's patient from Sri Lanka, one autistic child, very good parents, they accepted for all the treatment, including transplant. Post-transplant, the child had a relapse. And then we tried sorafenib, because Dr. Muhammad Raila suggested that as a role of hepatocellular carcinoma, which we have never tried. 4 places metastasis post-liver transplant. The child is well now for 4 years with sorafenib. But with that article, many phone calls have come to me. Have you tried sorafenib after that? Because we tried sorafenib, we didn't get much of response. I have also tried 7 or 8 times. The child, nobody has responded. So that is one thing which is not explained, why that child who had multiple relapses post-transplant responded to sorafenib. Next slide. So there is a role of sorafenib probably in hepatocellular carcinoma, but not in hepatoblastoma. That is another one concept everybody should know, that some authorities recommend irinotecan as a maintenance therapy following a relapsed hepatoblastoma and in metastatic site which was removed. If you expect a relapse in a high-risk cases, you can use irinotecan maintenance. In that, one important point is irinotecan is available as an injection. Even in COG in USA, they give that injection irinotecan as oral irinotecan. It is acceptable legally. So something which you can explore from the literature, maintenance therapy with irinotecan of difficult patients who are cured and high risk for relapse. Next one. High dose chemotherapy with autologous rescue has no benefit in that. Next slide. Okay, we are not going to discuss this in detail, but you should be aware there is a concept called TACE, which can be used as a bridging to liver transplant or as a palliation. Next slide. The final important point is, when will you consider liver transplantation? Pretext 4 or multifocal or centrally located. These are the 3 points. But the pretext 4, if the chemotherapy downstage, you can still try a liver resection. But that concept should be approved by a pediatric surgery team in conjunction with the liver transplant team. Because, next slide, if you land up with the rescue transplant after a primary resection, your prognosis will be extremely poor. So this is one point if you want to learn. If you are treating in your clinical practice a child with hepatoblastoma, and you do all heroic things without involving the liver transplant team, and you are very happy that the child has been cured, and if the child has a relapse, then legally there is a point that upfront transplant would have cured that child and prevented the relapse. That is some important point. Next slide. So this is a paper which is very significant. That next point, which I'm telling, an important point is, post-liver transplant, there is a role of chemotherapy. So this is a concept which is not acceptable by many people. There are various regimens are suggested. What we practice is, after we have got at least 16 patients with hepatoblastoma who were transplanted, and around 12 patients are alive and well. All the 16 had 2 cycles of post-transplant chemotherapy. ICE is the chemotherapy recommended by COG. Any chemotherapy is okay, irinotecan based, but there is a concept that during transplant, there is a risk of micrometastasis of vascular invasion. So every authority in COG recommend post-transplant chemotherapy, 2 cycles. And that this study has proven that randomization between, not randomization, comparison between the patients who were treated with post-transplant chemotherapy and not treated with post-transplant chemotherapy, there is a significant survival outcome difference. Next slide. Okay, I have seen one child with cerebral metastasis with hepatoblastoma, and this is not my article, but I can see that in the literature also. So other than lungs, very advanced children with hepatoblastoma can have cerebral metastasis also. Next slide. So these are the 2 articles which we have submitted, we have published. Multidisciplinary management of hepatoblastoma, one from Mohammed Rela's team and another one is from SRMC. Next slide. Next slide. The prognosis is stage 1 or pretext 2. The standard risk are all 90% survival. And then the stage 4 is still the 20%. But with liver transplant involvement, the stage pretext 4 also, or the high risk also, is having a very high chance for cure. Next slide. Okay, this is a child. Coincidentally, the second patient actually died 1 hour before. The child was declared as palliation, had breathing difficulty, died in the home care with our telephonic consultation management. So I would suggest that every fellow who's participating in this class should make yourself as comfortable as possible to deal with palliation. Parents will become very upset, whatever institution you belong to. If you treat a child with oncological management or hematological management or transplantation, and when the child is declared as palliation, if you shut the door of your hospital, or if you declare that you don't look after palliation, that is not very good. These are 4 concepts in pediatric hemato-oncology: hematology, oncology, palliation, and transplant. These are 4 stages in your life. Your fellowship, after you finish, if you go to a hospital, and if your hospital administration tell you to start transplant as your first patient, that may be your last patient. This may be a rude statement, but unless you experience a course of hematology, oncology, palliation, and transplant, it's good for you. I'm not saying that everybody has to go through. At least your hospital should have gone through that. You can't start transplant without dealing 1 year of hematology and oncology, at least for your residents and your junior doctors, pediatric department, and nursing staff. So one message from me is all the 4 components should be there in pediatric hemato-oncology, and transplant should be the next level, or at least 1 year after the hematology, oncology, and palliation. It is like Mada, Pita, Guru, Devo. You can't directly go to the God without respecting father, mother, or Guru. Next slide. Okay, the last point. So as I mentioned, the 2 important subjects which we touched was, one is the exam, another one is clinical practice. Okay, for an exam, you should look at the syndromes, also for clinical practice, but the questions will be, what are all the risk factors, which is the highest risk factor, it is low birth weight, any rare manifestation, precocious puberty, what is the reason for thrombocytosis, age-wise differential diagnosis, and for practical purposes, you select one protocol. It is like one religion, which you follow. It's not the only thing which is correct. Don't blame others. When you go to a hospital, from one hospital to another, if they are managing COG, if child relapses, don't say SIOPEL is correct. That kind of controversial statement will become a big problem in the hospital. You select a protocol, you go through the multidisciplinary tumor board, you stick on to the protocol. Even the first patient relapses, your protocol is correct and legal. Some important practical points are decline of AFP, pre-surgical AFP, post-surgical AFP are very important. And chest nodules should be resected. it will not usually respond to chemotherapy. Rescue liver transplant versus upfront liver transplant is extremely different. Don't try too many things and then refer to a liver transplant team. Remember, in this era, liver transplantation is available in many places. In Tamil Nadu, it is supported by government. So liver transplant is not something which cannot be explored, and post-transplant chemotherapy is needed. Next slide. Okay, so now I'm sorry that Janani could not read that second case, but I would appreciate her because everything which was prepared was just mentioned by me at one word, and she has gone through in one day. She will come back with 20 slides. That is how the slides were prepared. It is nothing to do with me. I was only just informing her and telling her a few minutes. And I thank IAP for this opportunity and all my experts who participated in this. And the slides, if somebody wants, can be shared, except the pathology slides for the league purpose. And please go through the hepatoblastoma topic always as a student and also as a consultant. This is what every fellow should be. MBBS is student, MD is a student, but fellowship is a consultant. So the next day after the fellowship, you are a consultant. But always read like a exam going student. The student inside the consultant should be always there. Thank you very much. Any questions? We are happy to answer. I think we have just finished in time. Please give your feedback.
Thank you very much, Dr.
Scott, for your exam.
Dr. Scott, excellent. I think you have basically built the topic, in a great way. It has been a mix of the all basics, also what's relevant in our day-to-day practice. You have touched on the rarer aspects of hepatoblastoma and also some, good insights about histopathology. So thank you, Dr. Mukul, for those, beautiful slides and the discussion around those. So, Dr. Scott, we still have a couple of minutes, and there are 2 or 3 questions here, which I think have not discussed yet. So there is a question that if a child has pretext 4 or high-risk chemotherapy with super PLADO, and there's persistently elevated AFP even after 3 cycles, so would you consider a change in the chemotherapy, maybe based on iron taken?
Yes, surely. See, the liver transplantation team whom I work with, Dr. Muhammad Rela, will never accept a surgical resection or a liver transplantation unless we bring down the AFP. There is no point in giving more than 4 cycles thinking that 1 lakh will become 90,000 or 80,000. If there is no dramatic decrease after 4 cycles, sometimes we would consider a biopsy if you are having no biopsy and started chemotherapy, but definitely chemotherapy change is required. And I have noted that not much of the children who had poor response to PLADO has responded to irinotecan or responded to ICE. That is something which very, very rarely we encounter a success for a 2nd salvage or 3rd salvage. But we have to change the chemotherapy and give a try before we declare that this chemotherapy is not working. But with a very high AFP of lakhs, we should not go for surgery or any liver transplant.
So now there's a question on PET scan. I think we have briefly touched on the diagnostic PET scan, but if the question is that patients who AFP is not declining or it's in fact increasing, is there a role of PET scan if you're not done it at the beginning?
No, I think PET scan is not recommended just for hepatoblastoma sake. If the AFP is increasing, you need an imaging. CT abdomen or CT chest is enough. If there is a small nodule, the PET also will not be having the uptake in the very small nodule. So basically, you have to correlate the AFP and the CT scan. PET is not going to give a major advantage in that. Yes. I have not been practicing PET scan.
And what's the time, the question is, what's the time will address pulmonary mets? What time point in your treatment schedule?
I don't think there is any time point, but if there is a rise of AFP after a hepatic resection during follow-up, if there is a significant rise, then we have to do a chest and abdomen. I don't think there is a typical time frame.
Other way around, if the patient is presented with if the patient is presented with pulmonary mets at diagnosis, and what time will you deal with the metastatic?
No, we do a CT chest before the surgery. So the concept is very clear. You have to resect the metastasis either during that resection. That is a surgical decision because the cardiothoracic surgeon sometimes might be involved. So I don't think it's a correct answer, but the mets have to disappear or mets has to be removed before you go for an extreme resection or a liver transplant. Sometimes after the resection, you can plan your pulmonary mets resection, but the liver transplant team will not accept if the mets in the chest has not disappeared or not removed. So for legal purpose, you are applying for an insurance scheme. I don't think you can apply for a scheme with the metastatic disease and apply for a liver transplant. That's something which we'll explain.
I think that Dr. Viba, I think the question you had asked probably what Dr. Scott is trying to say, that if there's a liver resection required, that may be a time point where you can do the lung resection as well, resectomy as well, if it's possible to resect it that time. But sometimes they can also space the two surgeries out, do a liver resection and then do lung resection later on, metasectomy. But what is also trying to say that if there's a liver transplant planned as a part of the local control in the liver, then it's better to have metastectomy done before and have a demonstration of a CR elsewhere before you embark on a bigger treatment like liver resection. So that's, I think, what.
But it also correlates with your AFP.
Yeah.
Because I don't think the chest nodules can be categorically told it is disappeared. But if the AFP is normal and it is a very small nodule, sometimes that we have to take a decision that it is in remission.
All right, so that's it. I think Dr. Scott, and we have, I think, you've addressed all the questions in the chat box as well. And once again, thank you very much for putting this interesting session together, and a lot of hard work Janani had done to make the presentations and put the information together. So thank you to you and your team, and more importantly, thank you to the the experts who are invited today for giving their expert comments on the various aspects of this multidisciplinary tumor, which needs multiple people to be involved. So thank you very much for your insights today on this topic. And I should thank Anand and Neeta for helping us to coordinate these sessions every week. Ria for the technical support, and also Echo for giving the platform. So we'll see you again in 2 weeks' time, and have a good evening, all of you. Thank you very much.
Thank you, Sunil.